Okay. Assalamu alaikum. We will start this session. We have Miss Lisa, 27 years, complaint of loose motion. The blood investigation AST 75, ALT 150, alkalis state 344, 45. The timer, then we will start.
Okay.
Wait, please, just a minute. A moment only. Yes, you can see now the timer. Yes, let's start. Here you go.
Okay. Hello. Good evening.
Good evening.
My name is Dr. Ahmed, one of treating doctor in clinic today. May I confirm that you are Miss Lisa, 27 years old?
Yes, doctor. Yes, I am.
Miss Lisa, we are here today to discuss some issues related to your health and examine you. Is it okay with you?
Okay, doctor.
Okay. Miss Lisa, I have a letter from your GP stating that you have been troubling with loose motion. Can you tell me more about this?
Yes, doctor. Since 6 months now, I have this loose motion. I don't know why.
Okay. Did it start sudden or gradual?
Sudden, doctor.
Is it the first time or you have previous or you have previous symptoms like this?
Before that, it came like 2 days, 3 days. But now, doctor, it is every day, doctor, since 6 months. Only for 3, 4 days, and then again for 2 weeks or more.
I'm sorry about what you have been through. I will help you as much as I can.
Thank you.
Okay. Okay. How many times per day?
And now, doctor, it may be more than 6, 7, 8.
Okay. So, does it contain any blood?
Yes, doctor. Sometimes contain blood.
Is it easy to flush or no?
I don't know, doctor.
Have you noticed anything increases this loose motion?
Like what, doctor?
I mean, is it related to, have you noticed anything like a specific type of food or no?
No, doctor, I didn't notice that.
Okay. Well, do you have is it associated with any tummy pain?
Yes, doctor, there is some tummy pain.
What is the site exactly?
It is colicky pain, doctor, in all my tummy.
Is it localized or go elsewhere?
All my tummy, doctor.
Well, okay. So, yes. Hello.
Yeah, doctor.
Any change? Okay. Does it wake up you from sleep?
Yes, sometimes, doctor.
Okay. Do you compensate well and drink a lot of water?
I try, doctor, but it is hard for me because it is many times now.
Okay.
I
Any tummy
try.
distension? Any tummy distension?
No,
Okay. Any change in the color of your eyes?
no, doctor. I didn't notice.
Okay. And difficult of swallowing?
No, doctor, I didn't know.
Okay. Okay, Miss Lisa. Any eye pain?
Sometimes I had eye redness, but it comes and goes, doctor.
Okay. Any joint pain?
No,
Any joint swelling?
no, doctor.
Any skin changes at all?
Actually, doctor, I have skin exchange, but I don't know if it is related or not. I will
Can I
share
have?
it.
Okay.
I will share it.
Can you please? Okay. Can you stop the timer?
Sorry, what happened?
She
Hello?
want to share. Yeah, she wants to
Okay.
share the
Ah,
photo
okay.
of the
Yes,
rash.
yes.
Okay.
Okay.
I share.
Okay.
Okay.
Actually, doctor, this is started very small, and I think it is insectified at the beginning. And I
Okay. Is it?
didn't seek any medical advice for it. But by time it is increasing.
Okay. Is it itchy?
No, it is not itchy, but it is oozing and it is increasing by time.
Okay. Anything increase this rash or this anything increase this oozing?
Like what, doctor?
I mean, have you noticed exposure to sunlight or anything?
دقيقة ترى.
Sorry?
I didn't notice.
كويس حارة أجي أطلع عشان أتحرك أمشي.
Yes. Is it numbing?
No.
Is there an other side?
No, doctor.
Okay. Well, and loss of weight.
Yes, doctor. I have been lost weight about 10 kilograms over these 6 months.
Is it intentional?
No.
Okay. Any lumps or bumps anywhere in your body?
No, doctor.
Okay. Any loss of appetite?
No, doctor. I eat
Any
regularly.
any high body temperature?
No.
Any tiredness?
Yes, doctor. Because of this loose motion, I feel tiredness and I feel easy fatigue.
Okay. Well, Miss Lisa, any chest pain?
No.
Any okay. Any awareness of your heartbeat?
No, doctor.
Any lower limb swelling?
No.
Any cough?
No.
Any cough and blood?
No.
Any noisy chest?
No, doctor.
What about your water work? Is it normal in color?
Yes, doctor. It is normal.
Amount, frequency?
I didn't notice any change.
Okay. Any history of traveling outside?
No, doctor.
Sorry?
No.
Okay. Miss Lisa, can I ask you a private question if you don't mind?
Okay, doctor.
Are you married?
Yes.
Okay. Well, any chance to be pregnant?
No.
Any using of birth controlling pills?
Yes, doctor. I am on contraceptive pills.
Okay. What about your period? Is it regular?
It's regular. Yes, regular.
Okay. Well, sorry for this question. Any extramarital relationship?
No, doctor.
Okay. Miss Lisa, any past medical illness I should be aware of?
No, doctor.
Give me your medication list.
I didn't take any medication.
Okay. Any family history of similar condition or similar problem?
سوري يا جماعة معلش في حد عامل شير سكريننج على الجروب.
على الجروب؟ لا ايه مش فاهمة.
Hello?
ايوه.
Hello, what happened? Sorry,
حد عامل
doctor.
شير.
Someone sharing the screen. You can see the timer now?
Yes.
Yes, now yes.
Okay, go ahead.
Okay. Do you smoke?
Yes, doctor.
How many cigarettes per day? For how long?
About 10 cigarettes. For now, about 15 years.
Okay, Miss Lisa, smoking can worsen it has a bad effect on your health. I advise you to stop smoking, and if you want, I will refer you to smoking cessation clinic.
Okay, I think about it. Thank you.
Okay, do you drink alcohol?
Yes,
How many units per week?
about 3 units per week.
Okay, Miss Lisa, because of your current condition, I advise you to stop drinking. I mean to stop alcohol until further assessment. Is it okay with you?
Okay.
Okay. Well, can I examine you? Before that, Miss Lisa, what do you do for living?
I'm a teacher.
Sorry?
I'm a teacher.
And how the disease affects your job and daily activity?
Actually, I can't. I can't. I didn't do anything in my job now. I leave my job, doctor, now, because I have faith from this lose motion, frequent lose motion.
I'm sorry about that. I will refer you to occupational doctor to give us leave sick leave and until further assessment and how to see how we can help you.
Okay, thank you.
Okay, do you drive?
No.
Okay, that's good. So can I examine you?
Yes.
Okay, and what about vital?
Vital blood pressure 110 over 70.
Sitting and standing, any different?
Any difference? No, no difference.
Okay, pulse?
Pulse 90.
90. Okay. Okay, eye examination, any blemish?
No,
I need torch for any redness or ulcer?
no ulcer.
Mouse examination, any mouse ulcer?
No,
There is no blur, right?
no, no bad.
Okay, I would like to examine the abdomen about any tender. What is the site of tenderness?
Now, no, there is no site of tenderness now, and no abdominal
No
pain.
site. Any organomegaly?
No,
Okay, auscultation of bowel sounds?
auscultation of what?
Bowel sounds. Auscultation of the
Normal.
bowel sounds.
Normal.
Normal. I would like to do perrectal examination.
Normal. Nothing.
Okay, so I would like to examine this ulcer, size, and in duration, if there is redness.
As it is the hook.
Okay, so pulse in the lower limbs.
Normal.
Normal. Okay, I would like to examine cardiovascular examination.
ما في نت.
Normal.
Sorry, normal. Chest.
Normal.
Normal. Okay, back examination.
Nothing. Normal.
Normal. Okay. Well. Okay.
Now 2 minutes remaining. The timer is late. 2 minutes remaining.
Okay. Okay. What do you concern, Miss Lisa?
What do I have, doctor? What's the problem with me? Why this lose motion?
I highly appreciate your concern, Miss Lisa. From what you said to me and after I examine you, you most probably have a disease called inflammatory bowel disease. It is a medical term for medical condition in which there is soreness in it's multi-system disease and cause soreness in different organ in our body, explaining the symptoms that you have. It might affect your tummy and sometimes affect your eyes, and sometimes it's associated with ulcer that you have. What we need to do now is to do some blood tests and imaging, and we need to do, and sometimes we might need to do camera tests to confirm our diagnosis and to exclude others. Then we will sit together to discuss proper plan of management, which will be by group of specialists, including the gut doctor and eye doctor and skin doctor, and might also be need to take a snip from this ulcer, and then a specialized nurse.
Okay.
Am I clear?
Clear, doctor. What about my leg skin rash, doctor? Is it treatable? Is it related to this disease also?
Yes, as we have discussed, this leg ulcer and this leg lesion might associated with this condition that you have. And
Is it treatable?
regarding your second concern, it is related to the activity of the disease that you have, and in most of cases it might be treatable, but I'm sorry to tell you that I might be recur again.
Okay, thank you.
Okay, time is up.
Okay.
Time is up. Let's go to the examiner time.
One more question.
Okay.
What's your diagnosis and what's your differential?
Okay, this 25 years old presented with chronic diarrhea for 6 months, which is bloody and more than 6 times, and associated with loss of weight and and also there is leg ulcer about 3 to 5 by 3 by 5 centimeters with redness at the base and indurated, and this consistent with bioderma gangliosum, this ulcer, and her symptoms suggestive of inflammatory bowel disease, most probably ulcerative colitis.
Okay. What about this patient? What other differential? You have any other differential diagnosis?
Yes, the other differential, it could be infection, but again, is that there is no fever. A simple infection, simple infection, but there is no fever. It might be due to malabsorption syndrome, and the other differential could be carcinoid syndrome, but again, is that her age, and I could not find another symptoms. The other differential could be, and the bottom of differential could be HIV, but again, is that there is no extramarital relationships, and this is a differential.
Okay. What about the high liver enzymes?
Okay, regarding the high liver enzymes.
She has AST 75. Is it normal? ALT
No, it's not. No, it is abnormal. Yes, this might be associated with primary sclerosing cholangitis, which is associated with ulcerative colitis.
Yes. Okay. You said to me it is the ulcerative colitis.
Yes.
As I said to the patient, it is inflammatory bowel disease. What types of inflammatory bowel disease did you know?
Most probably she has ulcerative colitis. The inflammatory bowel disease, either ulcerative colitis or Crohn's disease. But I need to confirm my diagnosis. Sorry?
What's the difference between ulcerative colitis and Crohn's?
Okay. From the side, ulcerative colitis, it's occupied to colon, while the Crohn's disease can affect the whole GIT. Regarding the extra GIT symptoms, the ulcerative colitis, the Crohn's disease, most of the time associated with joint articular joint symptoms, while the ulcerative colitis associated with eye symptoms. Regarding the manifestation, ulcerative colitis associated with body diarrhea, while on the other hand, Crohn's disease is not bloody. Regarding the macroscopic, endoscopic, I mean colonoscopic finding.
Understand, sorry.
Sorry.
Oh,
Yes.
Yes. Regarding the colonoscopic findings, colonoscopy, yes. In ulcerative colitis, it might. Sorry, I'm confused. I am. Is it? There is skip lesion in the ulcerative colitis, while in the Crohn's disease is continuous lesion. The Crohn's disease causes deep ulcer, and in ulcerative colitis affect the whole layer, right? Or
No,
I got confused.
Only ulcer. Only ulcer. Okay, we will be back. Okay, no
Okay.
problem. What is the management? How you manage this investigation?
Okay, regarding, sorry?
Investigation and the treatment.
Okay, investigation. I would like to do routine investigation, TB complete blood count, renal function test, and electrolyte and inflammatory markers. And I would like to do fundoscopy for her eye symptoms, and I would like to do colonoscopy and ERCP to exclude the primary sclerosing cholangitis. And that's it for. Yes, I would like also, yes, stool analysis and calprotectin.
Yes. Okay. How do you manage it?
Okay, regarding the management, acute remission and maintenance. Regarding the remission, I will give her methicillin and steroid, and the maintenance by methicillin.
هو both methicillin and steroid. But
Sorry?
acute management انت anti-diarrheal and symptomatic rehydration.
Yes.
Okay.
Okay.
What is the criteria of severity, doctor?
Regarding the criteria, actually,
Severity.
I cannot remember severity, but here true love criteria, but to be honest, I forget it. True love criteria for severity of ulcerative colitis.
التريتمنت وحضرتك فاكر التريتمنت بتاع البيوديرما جانجرينوزا؟
Bioderma gangrenosum by control the disease activity first, and then we might give her topical steroid.
Okay. Thank you, Dr. طلة. Very good done.
Okay, thank you.
بس هنرجع بسرعة كده بعض الحاجات. احنا عندنا البلافي دايريا.
Please, Dr. Shema, yes. Now, if you can talk loudly, little.
يا دكتور؟
Loudly. Raise your sound, please.
اوكي. البلافي دايريا differential diagnosis بتاعي هي infection كما الدكتور عبد الله قال، وانفلاماتوري وانفلتريشن او malignancy. اوكي، دول الثلاثة عندي اللي هم ايه؟ الثلاثة عندي اللي هم يديني بلافي دايريا. اوكي، بعد كده زي ما الدكتور عبد الله سأل، بس كان في سؤال بسيط كده زيادة، هو ايه؟ anyone of your family has same condition. Did you eat from outside؟ عشان اعمل exclusion ان هي infection. تاني حاجة الأسئلة بتاعت الانفلاماتوري وسألها كلها تقريبا. infiltration بس in anyone of your family has a similar condition, has cancer, any history of cancer of your family. بعد كده لو جينا على الانفستيجيشن، الانفستيجيشن زي ما قال بيزك انفستيجيشن وستول اناليسيس وفارتشر وفي كالكيل بروتكتنج وكولونوسكوبي. هو في سؤال الدكتور صلاح كان بيقول ان هو بيسأل اللي هو الفرق ما بين الالسراتيف كولايتس والكرونز. زي ما هو قال دكتور عبد الله ان الالسراتيف كولايتس بلادي، الكرونز بتبقى نون بلادي. الالسراتيف كولايتس بيبقى عنده في الغالب ابدومينال بين ماس، ليفت لور كوادرانت الي فوسا ماس، فوسا بين وستينيزمز، بين ما بيبقاش عنده ماس، بيبقى عنده بين. الالسراتيف كولايتس بيبقى عنده ليفت لور الياك فوسا بين. لكن الكرونز في الغالب بيبقى عنده ماس، بيبقى ماس دي بتبقى في الرايت الياك فوسا. اوكي. الالسراتيف كولايتس بيبقى الانفلاميشن في الكولون، ويبقى بس في الميكوزا. هو ألسر وكولايتس. ألسر يعني ميكوزا بس، وكولايتس يبقى في الكولون بس. لكن الكولونز بتبقى واخدة من كل الجي اي تي وكل اللايرز، كل الجي اي تي وكل اللايرز. اوكي معايا؟
Yes, Dr. Sharma, we can hear you. Go ahead. Yes, we
Yes,
can hear you.
yes.
اوكي. الكولونوسكوبي عندي في الالسراتيف كولايتس بيبقى فيها سودو بوليب، لان الالسرز الموجوده واخده حتت وحتت، فايه فمديها شكل البوليب للحته السليمه، سودو بوليب. هي مش بوليب ولا حاجه، هي سودو بوليب. لكن في الكرونز بقى عندها ديب ألسر ديب قوي، وسكيب ليجن، وحتت كتيره ما فيهاش، وسكيب ليجنز. اوكي. بقى عندها ديب ألسر، الكرونز عندها ديب ألسر وسكيب ليجن. لكن الألسرتيف كولايتس بيبقى عندها ايه؟ سودو بوليب. اوكي. في حاجه كمان بتنفرق بينهم اللي هي الايه؟ الباريوم انيما. الباريوم انيما بلاقي فيها سودو بوليب، في الألسرتيف كولايتس برضه هي سودو بوليب، وفيها حاجه اسمها درين بايب كولون، درين بايب كولون. لكن الباريوم انيما الموجوده، الصوره الموجوده في الكرونز، يبقى حاجه اسمها كاونتر سترينج ساين رود سورد ألسر. ممكن يوصل الموضوع مع كرونز للفيستula، لانها بتبقى واخده كل الليرز. يبقى روز سورن ألسر وكاونتر سترينج ساين وفيستula، ممكن توصل للفيستula. اوكي. بعد كده لو احنا
Yes,
قلنا التريتمنت، انا عندي نون فارماكولوجيكال وفارماكولوجيكال وسيرجيكال. نون فارماكولوجيكال اللي هو الاديوكيشن والكونسلنج والدايتيشن. مهم جدا الدايتيشن عشان الناس يبقى فيها مال ابزوربشن. خلاص. والفارماكولوجيكال زي ما الدكتور عبد الله قال، اندكشن اوف ريميشن اند مينتنانس. الاندكشن اوف ريميشن لو العيان عنده سيفير، وهنقول ايه الساين اوف سيفيريتي دلوقتي. لو هو سيفير هعمل له ادميشن، وهدي اي في، هدي كورتيزون، وهدي ميثايل بريدنيزون، هدي ميثايل او ميثايل بريدنيزون، هيدروكورتيزون او ميثايل بريدنيزون، بس هعمل ادميشن. وطبعا الاندكشن اوف ريميشن بيبقى برضه بالميثالازين والسترويد. خلاص. والمينتنانس كمان بالميثايلازين والسلفاسلازين والسترويد. طبعا ما انساش في الاكزامينيشن ان انا اشوف ساين اوف ديهايدريشن. العيانه بتقول ان انا ما بقدرش اكمبنسيت، فاعمل ساين اوف ديهايدريشن،
Okay.
سواء كان السكين تيرجر، او سواء الميكوزا بتاعتها فيها ايه، او زي ما الدكتور عبد الله كمان عمل اللي هو البلاد بريشر سيتنج وستاندنج. اوكي.
Okay.
بعد كده الكرايتيريا اوف سيفيريتي. الكرايتيريا اوف سيفيريتي في حاله السراتيف كولايتس ان يكون الستول اكتر من 6 مرات. خلاص. معاها واحده من اللي جايين دول، بس يكون الستول اكتر من 6 مرات في اول حاجه عشان اعرف ان هي سيفير ولا لا. الاقي معاها بقى واحده من الحاجات دي. الاي اس ار يكون اكتر من او بيساوي 30، more than او equal 30. البلس ريت more than او equal 90. العينه دي كانت 95، يبقى البلس ريت 90، الاي اس ار 30، التمبريتشر 38 or more than 38. الانيميا الهيموجلوبين بتاعها less than 10.6. اوكي. او السيري اكتيف بروتين more than
again, please. ASR, heart rate, and
heart rate and temperature.
hemoglobin.
هيموجلوبين 10.6. 10.6. اوكي. يبقى اول حاجه، اهم حاجه يكون الستول فريكوانسي more than 6 بير تايم بير داي. plus one of the following: ASR more than 30, temperature more than 38, pulse rate more than 90, hemoglobin less than 10.6. اوكي. في سؤال تاني ان هو increase the risk of cancer transformation لو increase the risk of cancer transformation if duration of the disease more than 10 years, onset of the disease before 15 years old، أو يكون الديزيز non-remitting، أو يكون pancolitis، أو يكون poor compliance. يبقى increase the risk for cancer transformation if duration of the disease more than 10 years، أو start beginning of the disease below age of 15، أو non-remitting، أو pancolitis، أو non-compliance. طيب احنا قلنا التريتمنت، معلش في حته نسيتها في التريتمنت ان هي سيرجيكال. امتى اقول للعيان ده محتاج سيرجيكال تريتمنت؟ لو دخل في توكسيك ميجا كولون، او fulminant attack not responding to the medication، او uncontrolled colonic bleeding. اقولهم تاني ولا خلاص؟
Yes, please. The criteria for surgery, indication,
توكسيك
non-response.
ميجا كولون، توكسيك
Yes.
ميجا كولون، fulminant attack not responding to medical، او يكون uncontrolled bleeding colonic bleeding.
Okay, thank you. The association, Dr. Shaima, please mention them. The LCC,
الاسوشيشن هو ايه؟ مش
primary sclerosing cholangitis in this patient.
لا مش في بالي. طبعا الاكسترا ارتيكولار مانيفستيشنز كلها، اللي هي الاي ريدنس
Extra intestinal.
اكسترا
Extra intestinal.
انتستاين. وعندي كمان البرايمري سكليروزنج كونجايتس، وعندي البايديرما جانجلونوز.
The joint with Crohn's.
بالنسبة للكحول هي she drinks like 3 units per week. لكن في حالة الليفر impairment whatever in less or more than weekly I should advise to stop not to moderate, right?
هم قالوا كده، قالوا ان اي
Any liver
infection
disease, yeah, any liver
أنا
excellent, yes. Yeah. What you did is perfect, Dr. Abdulmalik. Yeah. Okay, there is question by Dr. Ihda. What the signs of dehydration, Dr. Shaima, in this patient and in general?
signs of dehydration.
Yes, signs of in general and in this patient particular.
يعني مش فاهمه يا دكتور السؤال. الساين اوف ديهايدريشن زي اي ساين اوف ديهايدريشن، عيانه عندها ديهايدريشن وعندها دراي
Yeah,
سكين.
yeah. Yes, dry skin and mucous membrane, sunken
Yes.
eyes, and signs of
ممكن
posture hypertension.
كمان ده شهور تنشن
Yes,
وهايبر
sunken eyes
يعني صح.
and capillary refill as well. Yes, thank you, Dr. Fatma. Capillary refill, yes. More than 3 seconds. Yes.
في حاجه بس يا دكتور،
Yes, sure.
المفروض ان الميكوزا هيلينج يبقى ديتكتد بايه؟ بالاندسكوب، او ان انا اعمل فيكال كالبروتكتين من كل 3 ل 6 شهور افتر
This
انيشيشن.
for monitoring.
ايوه بالظبط. community.
Yeah, there is also survey for cancer colon in this patient.
survey for cancer colon.
Yeah, there is
By
possibility
colonoscopy
as a
يعني.
complication. Yes, colonoscopy. Especially those with the family history.
المفروض ان احنا بس مش دايما فاميليال، يعني هو مش دايما فاميليال.
Yeah, but there is possibility for being complicated with cancer colon. Especially as you mentioned the criteria after 10 years uncontrolled ulcerative colitis or family history of cancer colon. Okay, you're done, Dr. Shaima?
شكرا خلاص.
Thank you for the case, Dr. Shima.
Thank you.
Yeah, so let's comment first. Thank you, Dr. Shaima, for the case. It's a high yield case on topic in the exam. And I feel Dr. Abdulmanan is confident, mashallah, and too much perfect in the history taking and in the examination. However, I will just comment for the perfection more and more, either for you or for others, because there is also some system review you missed. I will mention to you there, and the other for our colleagues for other performance. I mean, okay, let's start from the beginning, from the complaint. Patient complaint was loose motion. So the onset course duration, as usual, onset course duration when it started, how was it gradually or all of a sudden, and the duration for how long, and you can add what improved, what worse. Then like the relation to the food, as you did, Dr. Abdul, you asked for a relation to the food to rule out celiac. Then the bloody question for bloody association is very important to conclude or to roll in and to roll out either inflammatory bowel disease or irritable bowel syndrome. Sometimes the bloody diarrhea will be the cutoff. Then awakening from sleep is very important because in irritable bowel syndrome, no awakening from sleep. The food relation you said, either with pasta or certain type food to roll out or to roll in celiac disease. The flushability, very important question. Is it flushable? If not, so it's malabsorption diarrhea. If flushable, it will be our case. I mean, in inflammatory bowel disease or other diarrheas. You can ask for the frequency and the consistency of the diarrhea, watery, bloody, soft, like that. Add to them the amount of blood. Is it bright blood or is it dark blood? It's very important here. Dark blood means upper GI bleeding, and it will be from above the ileocecal valve. This is for melena. For bright blood, you can have either ulcerative colitis or local cause for the bloody diarrhea, or blood in its stool, like hemorrhoid or sinus, for example, binodal sinus, bionodal sinus, or surgical cause. I mean, this is for the complaint. Then you go to the relevant system, as you did, Dr. Abdul. You went to the GI. The GI symptoms or signs: tummy pain, tummy distension, and you can ask for discomfort in the right tummy area. This is for the liver because you have elevated liver enzyme. This is particular question for that. And the jaundice, as you did, any change or anyone told you that your whitish become yellow or become paler than before. And the bowel habit, this is our case. Then you can ask for also for the difficult of swallowing. You can ask for the feeling sick, throwing up blood from the throwing up blood. This is very important question here also. Then the constitutional symptoms in this case very important. The loss of weight, as you did. Then the lumps or bumps, tiredness, temperature, high or body temperature, feeling tired, and night sweats. Back to the abdomen, you can ask any abdominal pain, or you can do it while examining the patient, any tenderness all over the body or over the tummy, sorry. Then you ask for other system will be very quick review. Headache, any dizziness, I mean for the syncope related to the severe dehydration. Any change of the vision, any eye change color, or like redness in our case. It's important here. No, not only the CNS, you miss another system. I will show you now. But it's okay, we are reminding for the perfection. Okay, the chest, the cardiovascular, you ask for chest pain, heartbeat, or awareness of heartbeats, and leg swelling. Perfect. Chest, cough, or short of breath, or cough of blood. Then any weather preferences, you might have any association with autoimmune. Any weather preference for the endocrine. Then The genitourinary, the system for water work, you didn't ask. I guess you didn't ask, or I don't know if you asked and I was not concentrated. Urine output is very important in this patient. You ask, okay, the color, the amount, and the frequency, and the fruitless. Okay, in this patient, you might have decreased urine output as a case of severe dehydration, pre-renal azotemia. Then we finish this, the joint. This is the second system you didn't ask. I guess the joint. Did you ask about joint pain? Okay, the joint pain here is important. Extra-intestinal symptoms. Good, great. I wasn't focused, sorry. And the skin rash, and she showed you that the skin rash, it was pyoderma gangrenosum. The criteria of pyoderma gangrenosum, remember that it's ugly rash and so much, deformed one. However, it's not painful. The opposite, erythema gangrenosum. Erythema nodosum, it's red one, and it's not deformed like this, but it's painful. This is the opposite of this rash, pyoderma gangrenosum. It is ulcerative, so much ugly, but no pain at all. Okay, this is the criteria for pyoderma gangrenosum. It will be necrotic edge, bluish, some oozy, ممكن maybe with pus, and the sensation will be, as I said, painful. Sorry, painless. Although it looks like painful, but it's not painful. Then the sensation above and below this, the hotness, and so on. This is for the rash. Then the system also you ask here, I'm writing here that you ask about the female history. It's very important. The pregnancy, the OCP, and the period. And whenever you ask for the period, say, I will ask you, sorry for this question, sensitive question. What about your period? Like this. You ask her, what about your period? You should ask initially or after even. Sorry for this question. It's sensitive question. Okay. Any miscarriage or any loss of pregnancy, as you did. The family history is very important, and you miss. I guess that you didn't ask about the family history. Why important? Either for the inflammatory bowel, some siblings, they got it as an inherited one, although it's not genetic, but it's like the running in family without genetic inheritance. The other reason for cancer colon, it's very important. Some people troll out or troll in, because this presentation might be like cancer colon. Who knows? Maybe a cancer colon patient, blood in the stool can be as a cancer colon. And there is what's called Amsterdam criteria, and some familial polyposis, they will present with this, like blood in the stool. So Amsterdam criteria 3 to 1, 3 family, 3 generation, more than or less than 50, and 2 generation more than 50, I guess. I always forget this criteria. If someone can share it. Anyway, it's important, this patient. If you have positive Amsterdam criteria, you might have this patient with positive cancer colon. Travel history is very important. If she has a history of travel recently, within 1 year, or within the duration of the complaint. In this patient, it was 6 months. So you can ask within 6 months, any travel history. It's very important. 3 family members. Yes, please, someone can write, then I will mention it. Okay, the travel, as Dr. Shemat said, maybe during travel he ate some food. Any family member with the same signs or symptoms, either troll out or troll in, food poisoning or gastroenteritis, infectious, I mean. And always, if there is positive travel history, ask where did you stay? Did you eat from local food, or you eat from restaurant, or the hotel restaurant, like that? The medical history, as you did, show me the medication list in a long-lasting disease. You have any surgery before? Very important to ask about surgery. Always me, even me, forgetting the surgical history. Why important here in this patient? Surgical history. He might have previous fistula as a Crohn's disease, for example, and fistula was repaired by surgery. Any allergy for any medication, it's important as well if you want to start some medication like antibiotics. HIV, as you did, you have partner, you have any casual relationships. This is for HIV. You can add also piercing, tattooing if you suspect HIV. Piercing, tattooing, sharing needles, recreational drugs. In this patient as well, you can ask for herbal medication. Some people using the herbal, and the herbal will cause diarrhea. Okay, then the occupational. What's your job? The smoking, the alcohol, and the driving. Sometimes driving is not related to, but if the patient is taxi driver, you can tell him, I can help you with the social or occupational work to help you if you're driving affected by your symptom. But in this patient, it doesn't drive, so it's good. The smoking and the job, yes, not always giving referral to occupational. You can by yourself give her sick leave. If you want to give sick leave, you can give sick leave if you feel like she deserves. No need to refer her to occupational worker. This is for the job or social worker. But you can ask her any support. If you need any support, we can refer you to the social worker. But for the sick leave, you can offer by yourself. But if for long-standing disease, you can refer for occupational to change the position if the patient needs to adjust the position or the job. Okay, so you're done with the examination. Started by vitals, good, heart rate, temperature, and blood sugar you can offer, and blood pressure, sitting and standing. Then the hand, cholinicia, bronychia, and bronchiectasis. Sorry, not bronchiectasis, sorry, clubbing. It's important here. The clubbing is associated with inflammatory bowel disease. You should rule out, or you make it as a routine. Whenever you do a clinical course or you have seen any videos for past tests, you start by the hand and you do all these steps. What are they? The pallor, the clubbing, cholinicia, polyclinicia, and any erythema or pulmonary erythema or any nicotine staining. Just act like you are looking for all these things. Nicotine is skin, and it's important here, but if the patient is smoking and COPD, you should do it. But I mean, make these steps as routine for you. Hold the hand and do these things. Imagine in any clinic, hold the hand of the patient and look for those 4 or 5 things. For infective endocarditis patient, you can also add splinter hemorrhage, Janeway lesion, and ocular nodule. This is for the hand examination. Okay, let's go for the vitals. خلاص, we finished the vitals, blood pressure. Then we'll go for the eye, any redness, any jaundice, any pallor. Look down, don't touch his eyes or her eyes. Let her pull her eyelid down. Don't do it by yourself. The mouth, open your mouth, show me your mouth. Any soreness, however, this patient is not having soreness because it's ulcerative colitis and it's confined to the colon. Then you go to the neck for any cardiac association or anemia or hypertension. If you suspect heart failure, anemic heart failure, you might have congested neck veins. Then the abdomen examination, very important here. As past test or as any abdominal examination, superficial palpation, inspection and superficial palpation, then deep palpation, lymph node. The pain, as Dr. Shema mentioned, it will be in the left iliac fossa, more related to the colon or rectum. Then offer inguinal lymph node and digital rectal examination as you did. Why? To rule out bleeding. Okay. Then the skin lesion, the epidermal gangliosum, you will do as a quick, then leg edema. Be systematic in any patient examination like this. You will not miss any system. The system is less relevant, make it quick. The most relevant, make it slow and more focused. Okay, our differential, this patient, inflammatory bowel disease, either Crohn's or ulcerative colitis. You can mention to the examiner both. Both are differential to each other. So whatever you are saying, you can say both. Inflammatory bowel disease, either Crohn's or ulcerative colitis. Then infectious one, gastroenteritis, either due to serious infection, HIV, if there is suspected any family travel history, you can add, but it's not necessary to be without family, don't mention it. Then cancer colon is very important in this patient as the patient passing blood. I think Dr. Shaima covered the topic for ulcerative colitis. I don't want to talk more lengthy because we have another
في
case.
نقطة بس يا
But
دكتور بعد إذنك.
yes, Dr. Shaima.
في نقطة بس بعد إذنك إن
Yes,
بتهيألي كمان
sure,
الليمف نود
yes,
المفروض إن إحنا نوفر الإكزامينشن بتاع
yes,
الليمف نود.
yes.
والسموكينج يا دكتور فيها ديبيت، فمش عارفة بقى نسأل عنه ولا لأ، لأن السموك أصلا بيحسن
No, no,
السيمبتومز.
no, no. It's, yeah,
بس
I
إحنا
will
لازم
clarify for
نبقى
you.
فيه.
Yes, yes. Although any bad habit can help any disease, but in general it will harm the general health. So even it improves, but still it harm. He might have cancer
يعني
lung.
يعني إحنا حتى ممكن نقولها كده، حتى هو بيقول لك إن هو ممكن يضر في صحتك، يعني يضر الصحة كلها.
Yes,
يعني أنت
you
بتقول إن هو
can say
ممكن
like
يضر.
that. Overall, yeah, it harm your health. However, some evidence, some research saying that it improves don't mention it unless he offer it. He told you, doctor, I read internet about internet or the internet that smoking improve my symptoms. Tell her, okay, yes, it's by evidence. Yes, there is some evidence showing that. However, it harm other systems and it might lead to certain serious cancers like cancer lung, and might be the patient will die from cancer lung and he will be saved from the ulcerative colitis by, for example, if secured by total colectomy. And he will die from cancer lung because of what? Because you didn't advise here that smoking can lead to cancer lung. Why? Because he's thinking that the smoking will improve the symptoms of ulcerative colitis. So it's not a reason to convince you that the smoking will improve my symptoms. You got it?
انا اعتقد دكتور يعني حد من الدكاتره اللي بيدوا كورسز كان قال ان هم ما نسالش عنها احسن هي دلوقتي، لكن انا حتى لما قريت عليها على النت لا احنا بنقول لهم يوقفوا.
Yes, exactly. I agree with this. So, but follow your sense, Dr. Shema. Don't follow the mentor. Sometimes the mentor, yeah, they are helping us, but sometimes the point doesn't make sense for you. But what you feel, do it. What you feel, do it. Don't follow the mentors. Okay?
I'm sorry. السلام عليكم.
وعليكم السلام ورحمة الله وبركاته.
كيف
Yes,
الحال؟
hello, Dr. Imaz.
كيف الحال؟ أنا I'm sorry شفت
Congratulations.
المسج بتاعتك late. Is the patient
Yes.
dying or palliative?
Which? Sorry, what patient?
عموما I just came late, so from your conversation I understand that if the patient dying or palliative or just a normal patient?
Okay. Yeah. This is for communication, you mean? Yes.
Yeah.
I agree with you. Yeah, if patient is dying and the last days of his life, don't tell him please stop smoking.
Yeah,
You can encourage him
don't
to
ask
smoke.
about
Yeah.
smoking أصلا. Don't ask about
Yes,
smoking
excellent.
or alcohol. You can ask about
Yeah.
circumstances at home, whether he wants to
Yeah.
let some of
Yeah.
his family know. Is he
Yeah.
well supported? Where does he want to go? What are the things
Agree.
that he like or dislike? Lakin, don't ask about the smoking or the alcohol at all.
Yeah. Agree. This is the only point you don't need to ask about smoking.
Yeah.
Yes, I agree with you, Dr. Rina. Thank you
Or
and
if the patient is
congratulations again.
you want to break bad news about smoking and break bad news about cancer with metastasis, برضو don't ask about smoking at all or
Yes. Yes.
or alcohol.
Yes, I agree. Yeah, I agree. Even the cancer lung and advanced cancer lung with metastasis, it's okay. He
Yes,
will die.
exactly.
Even
Yeah.
it's what the reason for his cancer. I mean, the heavy smoker or the heavy smoking was the reason of his cancer lung, and he will die by a cancer lung. But what it doesn't matter. It's already happened. So what the benefit if you advise him? It already happened, and he will die
Exactly.
soon because
Yeah.
yeah. Thank you, Dr. Maz, and again, congratulations.
Thank you so
We
much.
should
Jazakallah.
congratulate you.
Thank
Yes,
you so much. Jazakallah.
you're welcome. And yeah, you are our mentor now. You are our mentor.
No, you know what? I
You
think
part-
I should be advertisement أعمل لكم advertisement لأنه والله أنا من غيركم والله ما كنت حأنجح بجد
الحمد
والله
لله
يا جماعة جزاكم الله
الحمد لله
خير all of you. I'm
الحمد لله
very grateful. You have no idea how grateful I am. يعني
الحمد
thank
لله
you so much. لأنه أنا
الحمد
واحدة من
لله
الناس بتعلم بالسمع. So I'm more of a listener than a reader. I don't read.
الحمد
I get distracted and I never finish one page. Never. Wallahi, I just listen to you guys and thank you so much. I'm very grateful. Inshallah, all of you pass. I will keep praying for you every day,
inshallah.
inshallah.
Thank you. You know, we are so proud of you, and you
No,
are one of us. Yeah, you are one of us. Like you are too much depend on our group. That's why I'm so happy. And
exactly. Yeah.
yeah, I think I didn't see you practice anywhere. That's why I'm so happy because you are one of us all the previous day and the days before the exam. That's why I feel so proud of you. You did it finally.
Thank
And
you.
I don't have the words to say, but I'm really happy, Dr. Inas, for you.
Alhamdulillah.
Uh,
Alhamdulillah.
الحمد
توفيق من
لله.
الله. Thank you so
Yeah,
much.
الحمد
جزاكم
لله.
الله خير.
وإياك يا رب. Thank you, Sto. Okay. Yeah, stay with us if you have time.
Yeah,
Try
I
to be
will.
with
Yeah,
us.
I will.
Yes, please. Thank you so
عقبالي
much.
يا دكتور باسم. الو
أي دكتور نسيبة. Yes, I can hear you. Yes.
يا ان شاء الله عقبالي انا كمان.
والله
Yeah, إن شاء
جميل.
الله. All of us, والله.
think so. Really, I don't think so. Very bad.
No, no, no. Don't say that. Don't say that. One day, Dr. Rimaz was saying the same.
नहीं है तब जो था तो मैंने खुद ही अपने पाइप से खूब एक घंटे खड़े
Actually, Basim, you know that already I registered for that series.
Dr. Musaiba, ask Dr. Rimaz. One day she was with us like the same like you, stressed
You know
and
what? I was going to register for the third diet because I was thinking, oh my, 2 days ago, I was like, when is it gonna open? I really checked it and I put in my calendar to
oh my
just
God.
register for this diet just in case because I was too
Oh
scared of the new
yeah,
station.
yeah.
But alhamdulillah, and the abdomen station as well, because the man was frowning and he was mask face. He was so angry. But alhamdulillah, he gave me a good score. I was like, what's wrong with this man?
Yes, I
Alhamdulillah.
have always opinion. Don't judge the examiner look or the impression of the examiner. Usually he is like mask face, but he will give you the full mark. I know more
Yeah.
of the candidates. Yes, they did like that. Oh my God. بالعربي كده أنا عكيت في الستيشن. Then
This is the word I used.
yes,
شكلي عكيت لأنه his face
عكيت.
was
Yes.
so angry.
But you see, Alhamdulillah, yeah. You
طلع
don't
إنه ربنا
judge.
خلقه كده. This is how his face looks like normally.
Yeah, don't judge. And some examiner laughing and smiling at you, and he will fail you. So don't
Yes.
judge, guys, the examiner look. Sometimes it's different. And inshallah, Allah فوق كل شيء. يعني he's قادر إنه you pass even with this tough examiner with harsh comment.
Yes,
But
alhamdulillah.
still,
Yes.
yeah, you can do it. So Dr. Musaiba, be optimistic. You can do it. Really, really, wallahi, you can do it. How many for the last 2 weeks after Eid, how many good news we hear? And all of them, mashallah, they practice with us. A lot of them. So it's easy. Just do what you are practicing and what you are doing with us. Just try to condense your practice. Try to practice daily or like Dr. Imas, she was every day or at least every other day. One session communication, other session for long, other day for communication. Sometimes communication and long. It's okay. It's free and it's available. If you want, we give you a priority.
Even Dr. Basim, even I cannot practice because of my job. Still, I cannot take vacation. I listen to record. Here is second.
Yeah.
I listen to record all. Finish this record night all the day. Almost I keep it.
It's
I
okay.
try, but
Listen it. Yeah, listen it all over the day. No problem. You will
yeah,
learn
all
and you
over
will
the
have.
day. I
Yes,
keep it.
over
I
the
keep it
day.
by the word.
It's okay. I was
Yesterday
doing that.
this end life scenario
Yes.
for communication, I listen
Yeah.
about 3-4 times.
Yes. But if you
But I
follow
don't
these
know.
steps,
I can do it. I don't know because I
you
didn't
can do
practice
it.
well.
No problem. The repetition will teach you how to do. This is what we are doing. As Dr. Rima said, you can hear one information and it will be stick for the whole life. And you can read many times the information, but it will not be stick. This is the hearing aid of, the hearing way is very and much sticky to the information. You can do it by hearing and it will be more, as I said, stick. Try to hear and you will inshallah pass hopefully and be optimistic.
Inshallah,
Okay?
inshallah.
Don't worry,
The
don't worry.
problem I
Just
have,
try.
actually, I go through my first part Arab board anesthesia. So I take this both, my line is ICU. I take MRCB and anesthesia at the same time.
MashaAllah.
So
No problem, you
I
can do
get
it.
confused between each other.
You can do it, Dr. Nusayba. Just try to listen and or to practice. Okay?
Okay, I will try.
Yes, try your best. Inshallah, you can do it. Okay, guys, let's go to the next scenario. Dr. Domingue, you can give Dr. Shema the case.
Yes. I will send the scenario at the chat box.
Yes, please. I didn't read the comment. Let's read the comments quick. Okay. Smoking protective and answer the question. Yes, as I said, you can mention if the patient say it. The Amsterdam criteria. Yeah, thank you. Someone wrote it. Amsterdam criteria. At least 3 family members with colon cancer. Okay. The cases span at least 2 generations. Yes. At least 1 case diagnosed before the age of 50. Yeah, 3 to 1. Yeah, 3 to 1. 3 family members and 2 generation and 1 of them less than 50 years. 3 to 1. I'm always forgetting this criteria, but it's as 3 to 1, 3 to 1. I hope will not be forgotten again. Okay, the
Two
case,
successive generation.
2 successive generation. Yes, yeah, 2
Yes.
successive generation. Okay, Mr. Brandon, 55 years, peripheral sensory loss. Okay, good luck, Dr. Shema. We'll give you 2 minutes. Read the question.
One minute.
Okay, one more minute. Sorry, I cannot do communication today because I'm on duty and already the time is late. So we'll try to do it tomorrow because I'm on duty. Tomorrow I'm off, so we can do it. Okay?
You can start.
Okay, yeah. This
Good morning.
Good morning.
I'm Dr. Shemay, the doctor in the medical engineer today. Nice to meet you. Are you Mr. Brandon, 55 years old?
Yes.
Okay, Mr. Brandon, today we are here to discuss issues related to your health. Is it okay with you?
Okay, doctor.
Okay, Mr. Brandon, it came to my knowledge that you are complaining of loss of sensation in your feet and hands. Can you please tell me more about that?
Only hands. Okay. Yes,
Only
doctor.
hands?
My problem. Only feet.
Only feet?
Yes.
Okay. Okay, doctor. Okay, Mr. Brown. Can you please tell me more about that?
Yes, doctor. My problem just started 3 months ago when I feel this abnormal sensation in my legs, and then I went to doctor. Then he referred me to you.
Okay, both legs or one leg?
In one leg, doctor.
In one leg. Which
But
one?
in the right leg.
Right. Left
But
is
actually,
your
doctor, I mean in both legs.
both legs, but more in the right
Yes.
side.
Yes.
Okay. Okay. Up to where, Mr. Brandon? Up to where? This is
Up to my knee, doctor.
up to your knee. In both legs, up to your knee? Or in the right leg?
In both legs.
Okay. Mr. Brandon, can you please tell me when this problem started exactly? You said since 10 months?
I told you, doctor. Are you not hearing
months?
well? Because I told you 3 months ago.
3 months. I didn't hear it well. I'm sorry. Okay. It started suddenly or gradually?
It's gradual, doctor.
Okay. And increasing by time?
Yes.
Okay. Before these 3 months, you were completely normal.
Yes.
Okay. Did you notice anything that increase it or decrease it?
Like what?
Like what?
Mm.
Like hot. Okay. No, good. Okay. It is the same all the time. Yes. It is the
Yes,
same,
doctor.
same all the time. Is there any pain?
Yes. What do you mean?
Pain. Is there any pain? Any pain in your leg?
Ben,
No.
no.
Any trauma?
No.
Okay, Mr. Brandon, can you please tell me, do you have any past medical illness or surgical operation? You should be
Yes,
aware
doctor.
of?
Yes, doctor. I have high blood sugar.
High blood sugar. Since when?
Yes.
Since
I
when
think
you have this?
15 years old.
15 years
I mean 15 years ago.
15 years ago. Okay.
Yes.
What's your medication, Mr. Brandon?
I started with oral, but recently my doctor just changed my medicine to insulin.
Okay. Are you compliant in your medication?
Yes, doctor.
How many units you take from insulin?
Sorry?
How many units insulin you take?
30 in the 30
Yes.
before the breakfast and 10 before the dinner.
Okay. Mr. Brandon, what about the blood sugar that calculate the last three months?
The last one was
A1C.
the last one was 11.
11.
Yes.
Okay, Mr. It is uncontrolled, Mr. So it is uncontrolled, quietly uncontrolled. So, Mr. Brandon, can you please tell me, do you have any complication of the diabetes? There is any blurring of your vision? It affects your vision?
No.
Do you follow up in eye clinic regularly?
Yes, doctor. My last appointment was 1 month ago, and they told me I'm
Okay.
fine.
Okay. Okay, mister. Do you have any pins and needles in your hands?
No,
Okay, Mr. Brandon. Do you have any history of stroke or mini stroke?
no,
Any history of heart attack?
no,
Any pain in your leg when in the back of your leg when walking?
sorry?
Any pain in in back of your leg when walking? On
No,
walking?
no, no, no.
Okay, Mr. Do you have any? What about your water walk?
It's normal, doctor.
It is normal. Okay,
Mm.
no change in the color, frequency, amount.
No, at all.
No
No,
frosty urine.
no.
No frosty urine. Okay, Mr. Okay, Mr. Lincoln, can you please tell me about your diet? You take balanced diet. Balanced diet.
Actually, doctor,
Yes.
actually, doctor, I love pasta. I'm eating pasta all the time.
Oh, Mr. Brandon, you follow up with dietitian or no?
No,
Okay. Why you lost your follow up with dietitian? You should take. We need from you, Mr. Brandon, to take balanced diet and not to exceed pasta because it's so to control your blood sugar. Okay, Mr.
okay, doctor, I will
Mr.
do my best. I will do my best.
Okay, Mr. Brandon. Mr. Brandon, can you please show me your medication list other than insulin? Do you have any other medication?
No, just I'm taking metformin along with this insulin.
Okay, Mr. Mr. Brandon, do you drink alcohol?
No,
Do you smoke?
no.
Okay, Mr. Brandon. Can I ask you some questions? Mr. Brandon, it appears it is not relevant, but it will give me an idea. Okay.
Yes, sure.
Okay. Do you have any headache?
No,
Do you have any dizziness?
no,
Any loss of control of your bowel or your water work?
no,
Okay. Any abdomen, any problem in your swallowing,
no,
your vision? You said no.
No.
In your vision. Okay.
Mm.
Do you have any heart racing?
no,
Okay. Do you have any shortness of breath?
no,
Okay. Do you have any swelling in your leg?
no.
Do you have any cough?
Cough, no,
Any cough of blood?
no,
Any noisy chest?
no,
Any tummy pain?
no.
Any early satiety after early
Yes,
almost
doctor.
after?
Yes, doctor. Yes, doctor. I have noticed that. I just I'm taking just few food, and then I feel my stomach is full, and sometimes I have this bloating.
Yes. I'm sorry for that. I will try to help you. Okay, Mr.
Mhm.
Mr. Brandon, do you have any? You said you have any tummy pain?
No, at all.
Okay. Do you have any joint pain? Any skin rash?
No,
Okay. Do you have any back pain?
no,
Okay. Do you have any other past medical illness or surgical operation should be aware of other than diabetes or high blood
no,
sugar?
no, doctor.
Okay. Okay. What about your family history? What about your family history, Mr. Do you have any similar condition in your family?
No, doctor.
Your father or your mother? Any
No,
family history of food?
no, at all.
Any family history of sudden death or cancer?
No,
Okay. Mr. Brandon, what do you do for a living?
I'm a driver, doctor.
Okay. Is this complaint affect your driving?
Yes, doctor. Just this happened once when just I took my insulin and I didn't take anything. Just I felt dizzy, but I took some sweet and I back to normal.
Okay. I need from you please to stop driving until further assistance, Mr. Brandon. Okay, Mr. Brandon.
But it's my job, doctor. It's my job as driver. How to stop driving, doctor?
Only for a while until further assessment, and we will try to solve this problem. Okay.
Okay, thank you.
And I will refer you also to social worker and to try to help us regarding this. Okay.
Thank you so much.
Can I examine you, Mr. Brandon?
Yes. What do you want to examine? Hello?
I will examine the leg first. The leg. General
The leg?
inspection. There is
The leg?
anyone? Yes.
Okay. Let me send to you the legs of the patient.
Okay. Stop trying my doctor practice.
You can see the legs of the patient.
Sorry, I reset the time, but it was 10 minutes, so I will give you 5 minutes more.
Okay.
You send it to
are you
the
sure?
WhatsApp group?
Yes.
Yes. Mr. Brandon, I saw that that's your left leg is
Yes.
slightly swollen. Yes.
Mhm.
Okay. Any trauma in this leg?
No, doctor.
Okay. Any hotness? أشوف الهotness
No.
بتاعتها. Okay.
It's okay.
Any tender? Okay. It is hot.
No.
Okay. هشوف بين الصوابع is there any fungal infection.
Sorry?
هشوف ما بين between الفingers.
No fungal, no signs of fungal infection. No,
Okay.
no.
Can you move it, Mr. Passively? Can you move it? You will not
Restricted.
touch it. Huh?
No, restricted. Move.
Okay.
Yes.
I will check the sensation.
Mhm.
Sensation. Yes.
Sensation is impaired for all modalities.
Okay, in both legs. But mainly in the leg.
No. Yes, in the leg.
Okay. All sensation.
All sensation. Yes.
Okay. Then I will movement restricted. Okay. Okay. I will do tone power reflexes in the other leg. Okay.
Okay, normal.
Not touch this leg. Not touch this leg. Okay.
Mhm.
Normal tone power reflexes. Okay. Coordination.
Yes.
Okay.
How you want to do a coordination?
Coordination by finger to finger. Okay. Finger to finger.
Finger nose test. Finger nose test is intact.
Yes, is intact. Okay. Okay. I want to you walk Mr. Brandon by walking
Yes, I
gait,
can
yes?
walk.
Okay. Can you walk, please? I want to see your gait.
What else?
High step. What's the type of the gait?
The gait, it's yes, high step gait.
Okay. Mr. Brandon, tone power reflexes, coordination, sensation. After that, I will do a general examination to the pulse.
Before I sit down, do you want to examine anything else?
Romberg test. Please,
Okay.
Mr. I will support you. Please close your eye. Romberg. Okay. Okay, Mr. Brandon.
Okay.
Positive.
Negative. Yes.
Mr. Brandon, please sit down بقى مش مرتاح يعني. بعد كده
Okay.
شوف في الهاند بقى. Is there any affection in the hand sensation? I will check the sensation in the hands. Normal. Tone power reflexes. Okay.
Normal.
I will check the pulse. Is it regular?
Pulse regular.
Yes. I will check the blood pressure sitting and standing.
Intact. No difference.
Okay. I will check the أنا بتشيك الفيجن وأوفر الأندوسكوبي بس هو يعني لسه جاي من عند العيادة. أنا عندي وقت يعني ممكن أعمل. I will try to check the vision.
2 minutes remaining.
Okay. What's your concern, Mr. Brandon?
What's wrong
أنا
with
منتظرة
me, doctor?
الشربوشة هات لنا قال لي عندي في الثلاجة ستة أنا
What's
بقول له
what's wrong with me, doctor? And why my leg, this heart shape is different from the other leg?
I'm sorry for that. I will try to solve your concern, Mr. Brandon. Actually, from you said to me and after I examined you, you have long-standing high blood sugar, and this long-standing have bad effect in your nerves, in your nerve cables in your legs, making this loss of sensation and also making this joint deformity of your joint, which we call in medicine sharp joint. Don't bother yourself by the name. It means that small distractions in the bones of your joint, making this swelling. What we need to do now is to do some blood test and to do imaging in these legs, and we will do specific tests, and we will refer you to will refer to you to dietitian and to diabetic doctor, and also to food اسمها إيه يا ربي؟ food
Podologist. Podologist. Podologist.
أيوة. Okay, and I will after doing this test, I will sit with you again, and I will discuss with you the proper management plan and the result of the test. Okay. For the
Okay,
time
thank you
being,
so much.
I need from you to don't expose this leg to high weight. You should wear special shoes, and if you can use walking aid, don't be on it, and avoid any trauma for this leg. Okay.
Is it treatable, doctor? My leg.
Actually, it can be controllable, but it take long time. It take long time, and we need from you to stop eating pasta, a lot of pasta, and control your blood sugar, Mr. Brandon. Okay.
Okay, thank you so much.
Okay. Examiner.
Okay. So, what's your case about?
My case, this gentleman, 55 years old gentleman, has been diagnosed by diabetes since 15 years, and it is uncontrolled as moderate A1C level. He came complaining of loss of sensation in his both legs, mainly in the left side, which is swollen, and has the sharp joint in his leg.
Okay. So, what is your findings?
There is impaired sensation, all modality of sensation in both legs until the knee, and there is swelling left leg, with restricted movement, and loss of sensation.
Okay. What about the site of insulin injection?
I didn't check it. I'm sorry.
Okay. And what about the pulse in his right leg or left leg?
Oh, the pulse in the left leg, yes. I should examine the pulse in the left leg.
Okay. So, did you find another findings? Positive findings?
هي في ألسر صغيرة دي مقصودة؟
Yes, there is ulcer. Yes.
There is ulcer.
Yes, healed ulcer, right?
اسمها إيه؟
Yes, there is ulcer, yes, but healed, almost healed. Okay. So, yes. So, what's your differential diagnosis?
It may be trauma. It may be sharp joint.
What's your differential diagnosis for this sensory loss?
Peripheral sensory loss may be due to diabetes, maybe due to alcohol, maybe due to uremia, maybe due to vitamin D deficiency, maybe due to medications.
Like what?
Isoniazid.
Yes, isoniazid. So what's the differential diagnosis of, you mentioned that this patient has Charcot joint, right?
Has it? Charcot joint.
Charcot joint. Yes.
Yes,
What are the differential diagnosis of Charcot joint?
Differential diagnosis of Charcot joint can
Yes.
can be septic.
Sorry?
It can be septic arthritis.
So okay, what are the differential diagnoses of enlarged ankle?
Enlarged ankle?
Yes.
I don't think so.
Okay. So what's your differential diagnosis for this ulcer?
For what, doctor? مش سامعة.
Sorry?
مش سامعة. مش تاني السؤال.
A differential diagnosis of the ulcer of this patient. Ulcer.
Ulcer of this patient. It may be vascular ulcer. It can be
Yes.
it can be vascular ulcer. It can be neurogenic ulcer. Can be
Okay.
it can be vascular ulcer. Can be
Specify the vascular one and you will find
Yes.
two.
Yes. Is it venous or arterial?
venous or arterial. Venous. If the pulse is intact, it may be venous.
Okay. So how are you going to investigate this patient?
I will do basic investigation, and I will do in the form of CBC, renal function, liver function, electrolyte, and CRB and ESR. I will do blood sugar profile, fasting, and 2 hours, and hemoglobin A1C. Also, I will do X-ray. I will do X-ray nerve conduction velocity.
Okay. What do you expect to find in the nerve conduction study?
Decreased velocity.
Decreased velocity and regarding the action potential, what do you expect? I mean, what is your finding in the nerve conduction study in this patient with sensory loss? Decrease the velocity? Yes.
Yes.
Okay. Yes. What? Okay. What else?
I will do X-ray. X-ray
Yes.
and MRI.
Okay. MRI?
Yes. MRI.
Okay. Okay. So, what's the treatment?
The treatment control of the underlying cause, which is the controls of the diabetes. Okay. And I will do for treatment of the sensory treatment to this Charcot joint is to food caring by splint. I don't splint and don't move and don't bearing on it on the weight. Yeah, don't bearing weight on it.
Okay. Okay. Good. So, an indication for surgery?
Surgery?
Surgery for this patient, for his leg or his Charcot joint. Okay. Okay. Thank you, Dr. Shima. Now you can go to the next station.
Okay.
Well,
thank you.
Yes. Well done, but I have few comments. The first thing, let's start from the start. When you introduce yourself, I think it's better to start to mention that your last name, not your name. You told me that you are Dr. Shima. So it's better to start with your last name. Okay. Then the system involved here is the CNS or neuro. So after you analyze the symptoms or the onset or duration, and is it first time or you have previous attack? The most important thing, you didn't ask me about weakness. You have to ask me about weakness. So when the system involved, yes, you have to cover all the symptoms the system involved. In systemic review, you can mention 2 or 3 symptoms, that's enough. But the system that's involved or the main complaint in the systems, either neurology, cardiology, you have to mention all the systems. Okay. Regarding the diabetes, I think you ask well about diabetes. You have to once the patient is uncontrolled diabetes and you found that his hemoglobin A1C is 11, so the problem either one of 3, either drug problem, compliant, and you should examine the side of insulin injection. The second problem in the dietary, in such case, he has you should refer him to dietitian. Or the third cause, it could be due to daily exercise problem. So once the patient has uncontrolled diabetes, you have to ask about these 3 drugs problem, about either from the complaint or the site of injection of the insulin injection. Or the problem could be in dietary. In this patient, like he is not compliant with unbalanced diet, or could be due to exercise or sedentary lifestyle. After that, then I think you asked about the other history of diabetes, because the history of diabetes it takes a lot of time. So from the start, you should determine, is it type 1 or type 2 diabetes? This patient is 55 years old and has diabetes for 15 years, so this is type 2. And I give you the history of it started with medicine, oral medication, and then changed to insulin. The other thing is it seems that, yes, when you found that under controlled diabetes, we agreed that you should ask about the 3 Ds, drug, dietary, and daily exercise. After that, you should go for systemic review. In diabetes, you cover well the macro complication. You ask about myocardial infarction. You ask about his stroke and mini stroke. You ask about retinopathy. Whenever you found one complication, either a microscopic or macroscopic complication for the diabetes, you have to ask about the rest. You ask about blurring of vision for retina. You ask about proteurine for kidney, and you ask about stroke and mini stroke for macrovascular complication, and you ask about chest pain. And then for genitourinary, you cover them, chest, musculoskeletal. Musculoskeletal is very important in diabetes because has diabetic muscular atrophy, I think. And regarding the in diabetes history, the drug history is very important. You should analyze, and you didn't ask me about the duration for insulin, I think. For every medicine in diabetes, you have to ask about dose and duration. You asked me about the dose of insulin, but you didn't ask me about the dose of metformin, right? So drug history is very important in diabetes, especially in this sensory loss in the drug history. And you didn't ask me about general symptoms, because one of the differential diagnosis of peripheral neuropathy is paraneoplastic. You should ask about the general symptoms. 3 B's, like 3L, loss of weight, loss of appetite, lumps or bumps, and 3F, fever or high body temperature, feeling sick, or fatigue or tiredness. You should ask about, since it's one of the differential of peripheral neuropathy is paraneoplastic, you should ask about general symptoms. Regarding the examination, you cover most of them, but you did a mistake. I think it's a fatal mistake when you didn't check the pulse of lower limbs. It's very important in case of chapter joint or in diabetes especially. So please remember that whenever any patient with lower limb ulcer, you should check for pulse. It's mandatory. The other thing regarding the other investigation, you offer fundoscopy. This was great. Yes, you should offer a fundoscopy. And in the investigation, I should I think it's important to mention that urine dipstick for protein, and even they mentioned that it's a part of examination rather than investigation. And someone correct me if I'm wrong about this point. So in the examiner question, the differential diagnosis of Charcot joint is diabetes, number 1. 2, leprosy and syringomyelia can cause Charcot joint. Differential diagnosis of enlarged ankle, Charcot joint, osteomyelitis, or trauma. And you asked perfectly about if there is any history of trauma, and there is no history of trauma. Regarding the sorry,
the differential diagnosis of Charcot joint is
diabetes, leprosy, and syringomyelia. Yes, and differential diagnosis of sorry, your voice.
Causes of Charcot joint other than diabetes, leprosy, and syringomyelia.
Yes, leprosy and syringomyelia. And the differential diagnosis of the large ankle, Charcot, osteomyelitis, and trauma or tumor of the bone. Regarding the differential diagnosis of ulcer in the lower limbs or in diabetic foot, if in the heel, this most probably is neuropathic ulcer in the heel. If in the medial malleolus, this most probably venous ulcer. And arterial ulcer either in the tip of the tooth or in the tibia. And the difference between venous, actually all of these ulcer, the only painful ulcer that is arterial ulcer. Regarding investigation, I think you cover all of them, and in treatment as well. But yes, foot care is very important, and specialized cast, podologist, cast, or plus bisphosphonate has a role in treatment of Charcot joint. And last thing is control, of course, controlling of diabetes by controlling by diabetic doctor or dietitian or daily exercise. Indication of surgery in Charcot joint, I think that's joint instability. If there is unstable joint, it's an indication for surgery. And that's all about this case. If anyone has comment or adding point.
Thank you, Dr. Abdullah. Thank you, Dr. Shayma. Actually, for me, Dr. Shayma, you did great in this case because it's a complicated one. A lot of finding, a lot of positive things to ask, and a lot of covered point to ask as a complication, as Dr. Abdullah said, macro and micro. Yeah, she did all of these. It was impressive, really. You did it in perfect way. The only thing you missed, the impotence. You can ask about the intimacy. Yeah. Do you have any problem in your intimacy or intimate relationship? Mostly he will have, because he has a lot of retinopathy and all pathy of diabetes. So
actually, I mentioned the signs of floating and autonomic neuropathy for erectile dysfunction. Yes,
it's important to mention. So our system review in this patient, as Dr. Shayma did, is to roll out and to ask about all complication of diabetes, not the system review as we do. Yes, we can ask system review if we have time, but the most important is the diabetes complication, either macro or micro. The point also for the pulse during examination, when you said you will minus here, actually she asked one important question, and she can roll out or roll in the claudication. This is for vasculopathy, but I agree with you, she should do examination. But she covered the point of vasculopathy when she asked in the history, you have any pain while moving? So in general, she covered a lot of the points, and I think she will she will take around 95% of the complication of diabetes. So only
Yes,
the
she covered
intimacy
all
does
the
this.
important points.
Yes,
Yes,
excellent. For me, she will pass this station if she's I'm the examiner, I mean. So I don't want to
Yes.
talk more from the start. But as Dr. Abdulmenem said, you're Abdulmenem, right? This is your name?
Yes. Yes.
Okay. Okay. Then we will start. I will not talk about onset course duration. Yeah, but the only thing in the complaint, what the meaning of sensory level or sensory affection? You can ask this question. Either weakness,
Mhm.
motor, or sensory, as Dr. Abdulmenem said. So sensory, where the level, which side exactly, and to what sensation. And in the examination, you should do full neurological examination of the legs, as well as for the arms and for the cranial nerves, plus retinopathy, the eye, I mean. So let's talk about the diabetic macro and micro. Again, this is important in this patient, instead of focusing on the system review, because the system review will include most of this complication. For example, the chest, the cardiovascular, you have coronary artery disease. So in the history, you'll ask about any heart attack, as Dr. Shema did. Any heart attack, any chest pain while walking, or any leg pain while walking. So this is for the cardiovascular. Let's go to the CNS. Any weakness, any pins and needles, any tingling. This is for peripheral neuropathy as the case. Vision problem, yes, retinopathy will be affected. Absolutely, the patient will have it because the hemoglobin A1C is high. So what the vision affection you mean? Is it color? Is it night? Is it far? Is it and how you see? Is it hazy? You should analyze, and at the examination, you should offer fundoscopy. And very important to stop driving. Why, doctor? It's my job. This is for Dr. Shema. Why, doctor? This is my job. Okay, we can involve the occupational worker. They will help you in this regards, either to reallocate you to find a job for you, not depending on your vision. Why? Because he might be quit from driving. This is harming. He will harm himself or he will harm others. He's taxi driver. He depend on his eye. So by retinopathy, either to be corrected by laser photocoagulopathy or whatever the treatment or the solution. Till that time, as Dr. Shema said, we will reassess you, but we will stop the driving until we investigate and reach to the problem. Okay, but if he telling you, doctor, how can I stop driving? This is my job. This one you should interact. Yes, for this, we can involve our social to support you or to reallocate you by occupational work because he is concerning now about his income. It's very
بس هي يا
important,
دكتور
okay?
معلش هو هل يا دكتور هو كان عنده بس مرة واحدة loss of consciousness ما دخلش حتى قال خد سويتي وعمل
لا
هو
لا, I'm not talking about hypoglycemia. I'm talking about retinopathy. Not only
هو ما عندوش
hypoglycemia, Dr.
بس
Shim.
انا بعمل فولو اب مع الاي والاي كويس مفيش مشكلة.
Okay, because I missed some points. If he's okay from his vision and his vision is clear and
بس هو
fundoscopy
عنده
was normal.
مرة واحدة هايبوغلايسيميا هو عنده مرة واحدة
No,
في
no,
الهيستوري
no, no, I
مرة
didn't
واحدة
talk about hypoglycemia. I talk about the
ما فيهاش
retinopathy
مشكلة
itself.
أنا عارفة إن ما فيهاش مشكلة بس
Yeah, if intact, okay, خلاص. All what I said is cancelled. So just to reassure him, and we will reassess you by the ophthalmology and any hypoglycemic attack for a recent or previous hypoglycemic attack. If no, as we know, the policy for hypoglycemia awareness or unawareness, there is a DEVLA rule. However, he doesn't have, so no need to tell him about that. But if you have any of them, you can stop him temporarily till further assessment. Okay. So starting from up as I
عمي
did
مساء الهنا
from up till okay. So
جيت
sorry. Okay. So the CNS either retinopathy or sorry either neuropathy weakness or sensation or vision or retinopathy, this is related to the CNS. And a very important question, any stroke or mini stroke. This is for CNS as a system review and as a macro complication of diabetes. Then we will go to the cardiovascular. So the cardiovascular include chest pain or any heart attack. Then we will go to the chest, any cough, etc. related, maybe chest infection if he is immunocompromised, as we know. Chest infection, so chest pain, sorry, short of breath or cough. Endocrine is very important in the system review. If you suspect association with thyroid, for example, Hashimoto's can associate with diabetes. But again, the complication of diabetes is more important than system review. So if you go like this from up down, you will ask this question, either macro or micro. The second macro was heart attack, then the GI full of complication, either satiety, earlier satiety, or floating. The digestion, or diarrhea alternating with constipation, autonomic dysfunction, autonomic neuropathy, and finally, the diarrhea, and that's it. Or metformin as a complication, diarrhea related to metformin or whatever the medication he is on. This is for the GI. The genitourinary, again, important. Nephropathy is very important. It change the color, amount, frothiness, or frequency, or any UTI recurrent infection. It might be there. Then the intimacy. Sorry for this question. Do you have any problem with your intimate relationships? It's important, as well as impotence. Then the joint pain, any joint pain, and any skin rash. Necrobiosis, Lipotica, one of the association. So you can ask as systemic review if you have time. Then the extremities, vasculopathy. Vasculopathy for claudication. And from this point, you can ask for pedal pulsation in the examination. Then the joint, of course, a joint affected, like this case is Charcot joint. This is for the joint system. Family history, travel history, medical history is very important. What are you taking? Did you add any medication? Did you increase the dose? Are you compliant? And as Dr. Abdulmenem said, the injecting areas or the injecting skin point or areas. Are you changing them? Are you injecting well or perfectly? Are you compliant? As I said. Any long-lasting disease, because diabetes is not coming always alone. It comes with hypertension. You can ask, and atherosclerosis as well. Then the HIV, quickly, you have any problem or you have any casual relationship apart from your partner, if you have time. Constitutional symptoms is important here. Loss of weight, loss of appetite, lumps and bumps, as Dr. Abdulmenem said, and the smoking, alcohol as occupational question. Let's go to the differential. For me, I will not say the differential of Charcot because the case was sensation. Dr. Abdullah asked maybe as information, but in the case, the patient came with sensation affection. So I will say the differential of peripheral neuropathy. What are they? This patient, diabetic neuropathy, or if patient alcoholic, I can say alcoholic neuropathy, or drug-induced neuropathy. Or if the patient younger, I can say inherited one like Charcot-Marie-Tooth neuropathy. If they ask you the Charcot differential, as Dr. Abdulmenem said, yes, the causes of Charcot, leprosy, and diabetic. And what else, Dr. Abdulmenem? Drug. The third cause of Charcot, leprosy, and diabetic. Anyway, sensation affection. Okay. The workup, I think Dr. Abdulmenem also finished all the points in the investigation, and always remember the
بس انا كنت عايز
complication.
اسال سؤال يا دكتور، هو النيرف كوندكشن
Yes,
فيلوسيتي النيرف كوندكشن ستادي بنشوف فيه ديكريز فيلوسيتي ولا لا؟
amplitude.
ديكريز الامبليتيود.
Diabetes, yeah, but diabetes is
But
demyelinating
diabetes
disease.
can do both diabetes.
Yeah, can lead to go. Yeah, so
Yes.
it's axonal or demyelinating. I think
Demyelinating or axonal.
yeah, both of them are there, but the
Yes.
diabetes, yeah, in diabetes, I think axonal more, so the amplitude will be affected. It's not the demyelinating one, but both of them can happen. Okay. What else, Dr. Shaima, you want to ask about the complication? Fundoscopy, you did well. The examination start from the joint itself. As you said, look, feel, move, look, feel, move. Look around, it's deformed one. You feel it like deformed and disorganized, and the bone deformed, as I said. There is swelling, edema, and the next feel, look, feel above and below, and the deformity, the dislocations, you can feel it, but be careful. It's not painful, so you might move it aggressively and you might have dislocation because of your movement. So try to be very gentle while examining the Charcot joint. He doesn't have sensation. So the feelness or the feeling, feel it by dorsum of the hand for the temperature, but don't try to move it aggressively. Look, feel, move. The same for the movement. Ask him to passive move. He can pass. Okay, he can do it. But if you will do active movement, be gentle with the movement. Okay. Look, feel. This is for the Charcot. Yes, the ulcers. Try to search. I like when you search for the fungal infection. It's very important. He might have this, and it will be hidden under the sole or in the between the finger. Try to expose. The pulsation, you will see the ulcers all over. Medial malleolus will be venous, as Dr. Milian said. The big toe or the tip of the toe will be vascular, arterial, I mean. And neuropathy, it will be in the heel or in the sole. Neuropathy, because he doesn't feel it, and he might be hurted while moving bare naked or without bare foot, without shoes, I mean. He might hurt himself without feeling that. Yeah, very important, the hair distribution in the chin, it will be lost, no hair, and the color of the skin will be also like dark little bit. This is in the chin and all this, the feet, both feet. This is one of the peripheral neuropathy signs. The hair will be lost and the skin will be dark, or there is pigmentation. Others, the examination, retinopathy, fundoscopy, and blood pressure sitting, standing, vitals, as we do usually. I think we covered this topic in general. If any question or any comment, Dr. Abdelmani, yes, let's start from the beginning. What about driving after one hypoglycemic episode? Yes, if there is hypoglycemic episode, he should inform the VLA, especially if an awareness. But if awareness one, so he will know that he has the signs of hypoglycemia. But unawareness is very dangerous. He doesn't feel it, and he might be in a coma without alarming sign. We should ask about other differential of peripheral neuropathy than diabetes. Yes, agree. Syringomyelia, yes, this is the third cause of Charcot joint. Associated autoimmune pernicious anemia cases peripheral neuropathy. Whatever we are remembering, it's yes, it could be there, but try to cover these complications. The association, yes, agree to cover them. Whatever you add to what I mentioned, it will add to you the marks. But if you did what I mentioned, you will have the full mark. Association, yes, there is association, but you will miss the association, but don't miss the complication. Okay? Associated autoimmune, yes. Yes, you are right. You should screen for other autoimmune. Yeah, but in this case, patient has type 2 diabetes. Yes, I agree with Dr. Amina. Especially in this patient, we should find all complication rather than looking for the association. Although you can do it, but if you finish the complication, go to the association. Anyway, you will have the signs of anemia. If you have anemia, you will see pallor and you can suggest to the examiner. And might the examiner ask you, what do you think why this patient have pallor? You can tell him this association, but not to find it as a history of pernicious. What you will ask for the pernicious as history? You don't know how to ask it unless he has anemia. So the anemia can be picked up by examination. Or you can tell him, anyone tell you you are paler than before, or you can check it in the blood pressure sitting and standing like this. But the hypothyroid or the Hashimoto or thyroid association, you can pick up from the history, but the anemia you can pick up from the examination. This is my suggestion, and I hope we cover this topic well. Any question, any comment? Again, I apologize for the communication because I'm on duty. I don't have good time to focus, really. I'm trying much to focus, but sometimes I can't because of the patient care and some orders to be ordered. Any question, any comment before ending? Thank you so much, Dr. Abdulmenem. Really, it was impressing cases and impressing performance. I like your performance today. I hope you will practice with us again. This is the first time, but it looks like you are confident enough. Dr. Shaima as well, she was
Thank you
confident
so
than
much.
before. Yeah, thank you, Dr. Aminem. I hope you will practice again with us. And
Yeah, of course.
thank you. If even you didn't practice, share with us. I hope all will benefit from this. I feel happy when someone told me I just listened to the records and really I found one of our colleagues, she didn't practice with us more, but she listened to the records and she passed the exam. I hope we will be beneficial for all and will help all to pass this exam and not to be a nightmare for us. It's easy. A lot of candidate and colleague pass the exam, either practicing with us and others or practicing with us alone. This is my aim, to be free and to practice free. This is our vision, as they say. Practice free or study free, practice free. No need to take course. Wallahi, I believe on this, and I swear, no need to take and to pay a lot of money. This is my aim in the group. No need to pay. No need to pay. You can do practice either with me or whatever or whosoever, but don't pay for courses. They should decrease the fees for the courses. It's enough what we are suffering from the stress and the travel and the visas and the fee of the exam and the clinical course. And it's enough to pay for them. So no need to make a course and to pay a lot of money for the same what we are doing. Okay. Thank you all. I just deliver this message because I'm always focusing about not to mention mentors. Everyone is mentor, but by practicing, he will be mentor. You and me, and it's not necessary to pass. We can practice more and will be ourselves as mentors. Okay. See you tomorrow, guys. Thank you. I will stop recording, then I will nominate for tomorrow. Thank you all.